there. Okay. All right. We are live, and welcome to a CNY Fertility live stream. We're really grateful to have Dr. Barad from the Center of Human Reproduction, works with Dr. Gleicher. We had a really great live last week with Dr. Gleicher, and I know we're going to have equally great conversation with Dr. Barad. And he has a really lengthy CV with a lot of great accolades. And again, we're just really grateful. Dr. Barad, how are you doing this beautiful day?
We're doing okay. We appreciate the sunshine and the nice air that's returned to New York City finally today.
Well, it's good. It's good. Well, upstate New York, upstate in Syracuse has gotten better also, and we're just really hoping everyone's feeling the clear air that's coming.
Mm-hmm.
So maybe you could tell us a little bit about yourself and how you really came to be and working in New York, and then we'll talk a little bit about how the supplement world came into play in your wheelhouse.
Yeah. So, well, I'm actually a New Yorker by birth. I was born just a few blocks from where I'm working now in my office. I grew up in rural New Jersey. I did my fellowship, my residency at Columbia Presbyterian, and my fellowship up at Brigham and Women's, and then returned back to New York. I was at Einstein for a long time, 20 years, and then I joined Dr. Gleicher back in 2003.
Wow.
And Dr. Gleicher opened this office around 2001, just after 9/11, actually just before 9/11. The opening ceremony for this place was the day before, well, 9/10, before all hell broke loose for that. So when I joined him in 2003, he was still part-time in Chicago and part-time here. And we kind of quickly came to realization that the practice that we're going to develop would be not the same niche that most folks were dealing with, but we gravitated early to try to figure out how we can help those people who hadn't been helped in other places.
Mm-hmm.
And the idea we started, well, you know, when we were starting out, we used to question anybody over 38, 39, 40 whether they should even try to do this stuff. And at this point, as Dr. Gleicher probably mentioned to you, our average age of our patients is about 43, 44. I imagine you have some of that same experience up there now too. You know, when we started out in this thing that we've been doing for years, it would have been unheard of to be taking care of somebody in that age group. And
Right.
so, you know, what are you going to do for somebody short of telling to use somebody else's eggs? And we early on came to the DHEA, which you talked to Dr. Gleicher about last week, and then we had some success with that, and then it became into the field that other supplements could potentially be helpful. And I guess today we're going to talk a little bit about CoQ10, which is supposedly they are to try to help the energy metabolism of these eggs. We've been using CoQ10 for women and for men now for years. I think it's become sort of part of the armamentarium everywhere, although, as we'll discuss, there's a lot of theoretical and animal evidence in support of this, but the evidence in people is smaller, but worth talking about.
Yeah. So what if we can talk a little bit about maybe the causes of the damage that may be happening to the ovarian egg environment, the testicular sperm environment, maybe try to understand a little bit, what causes the diminished ovarian and sperm function that we're seeing so prevalently, and certainly in 40-year-olds, but younger and younger, we're seeing that in men and women.
Well, I mean, as men, we're kind of blessed with not having as much of an age-related insult. There are, I think, who was it that just had a baby? One of the older folks.
Was it De Niro or
De Niro? Yeah, one of those guys, and he's older than we are. So men don't have the same age cutoff as women, but you have to remember that these gametes, as they're developing, all have supportive cells that are there to sort of nurse them. In the case of the egg, it's the granulosa cells that support the follicle. Those granulosa cells are sort of connected to each egg. The sort of cumulus granulosa cells connected to each egg by little projections that project through the zona pellucida and are providing the energy that supports the cell as it goes through its development. And the energy metabolism of these granulosa cells lessens, gets worse as people get older. There have been actually fairly good studies that show that the CoQ10 levels in these granulosa cells and the follicles and in follicular fluid decrease significantly as women get older. And CoQ10 is part of the chain of events that provides the energy ultimately to form ATP, which ultimately is what powers our mitochondria, which are the batteries of all of our cells. And so these one thing that we've noticed, and we've all noticed, is that as women get older, the granulosa cells have a harder time continuing to play that supportive function, and there are similar cells in gentlemen, Leydig cells, and Sertoli cells that support sperm development. So, and it's a similar kind of relationship, although physiologically somewhat different. So supporting this energy metabolism has become part of what we're doing. Now, some folks would come to this and say, okay, we'll add the CoQ10 at the beginning of a stimulation cycle. But that doesn't really make sense, because all the business that goes on while you're developing an egg is going on for 3 months before you start your cycle. So as we're aware, from the time the primordial follicle kind of wakes up and starts making its journey out to be a mature follicle, there are many stages it has to go through, and it takes about 2, 3, 4 months for it to get there. That's why we start DHEA a few months ahead of time, and that's why if you want the CoQ10 to try to do something to play this role, you need to start that early too. And most people these days would recommend starting the CoQ10 it's like 3 months before you get to the point where you're going to be harvesting eggs.
How does someone know who they are that may need CoQ10 or other supplements to try to help with this? Is it, we can take it sort of just a generalization, or should people look at specific things to know that?
I don't think there's enough evidence to say to have an indicator of this person is CoQ10 deficient. I think that as a rule, I mean, people tell me, what's the best test I can do to see what my fertility is? And I say, what's your birthday? I mean, because the strongest predictor we have of anybody's fertility potential is their age. Beyond that, I think you can presume that anybody probably over the age of 30, 35, 36, probably could benefit in theory from using CoQ10. Now, to be fair, there's, as we said, pretty good evidence in mice that it improves embryo development and even live birth in mice. And there's less evidence in people, even though it's become ubiquitous and we're all using it. There's pretty good evidence that it will increase egg numbers, and to some people have found that it is able to increase AMH, which is direct relation to increasing antral follicles anyway, and quality. But a couple of studies showed increased clinical pregnancy. There's no good prospective randomized clinical trial that shows that it increases live birth. It just hasn't, and people have tried, but it just hasn't come around to that yet. So maybe we haven't found, maybe we haven't mounted a large enough study to show it. Maybe we haven't organized it properly. There's so many other factors that come into moving from, to the point of having a good embryo and a good baby. You have to kind of control the population and make all the other things equal. And that's kind of why you need a randomized controlled trial. And probably in this group, why you need a very large randomized controlled trial to try to show any kind of effect.
Is there a synergy with CoQ10 and DHEA together in those with diminished ovarian reserve or function?
Well, there's no, there was a randomized controlled trial in which they looked at women who were taking DHEA plus DHEA plus CoQ10. And the women who had the combination of DHEA plus CoQ10 actually did do better than those who were taking DHEA alone in terms of egg numbers, embryo quality, and I think clinical pregnancy. Again, they couldn't show a difference in terms of live birth, probably because the study was too small. There were trends for improvement, but they weren't clinically, statistically significant trends. So there is some evidence that there could be some synergy. On a theoretical basis, it makes sense because they're kind of working on different axes. So the DHEA is acting on helping to maintain small follicles, bringing more to the market, so to speak. Just to back up, we said the journey from primordial follicle to Graafian follicle while it's growing is 3 or 4 months. But what that really is a time when the hundreds or thousands of primordial follicles that begin that process are sort of competing with each other. I use the example of like kids in high school trying out for the gymnastics team, and some of them make the school team, and somebody there makes the regionals, and somebody makes the state team, and you go from thousands of kids in high school to a small group, and finally somebody gets to the Olympic team, and then they all compete for the gold. So right. That Olympic team is like our antral follicle count at the beginning of a cycle, and in a natural cycle, one ovulates. Of course, when we give our fertility meds, everybody gets the gold.
Right.
But during that process, the effect of androgens like DHEA, it helps to preserve those small follicles as they make that journey. It keeps them from becoming atretic, whereas the CoQ10 is preserving the energy metabolism and in a slightly a different axis. So it makes sense that the two could be synergistic together.
In general, the diminished ovarian reserve patient, the DHEA, you're testing their androgens and DHEA levels to determine whether or not they would get some benefit from adding the supplement.
So in general, we put almost everybody who has evidence of diminished ovarian reserve on DHEA. The reason why we test androgen levels when people are on DHEA is we don't want to go over the top. Our target for total testosterone is between sort of 30 and 60, 70, something like that, nanograms per deciliter. And our target for free testosterone is sort of 4 to 6 picograms per milliliter. If we see people who are running up to 100, 150, free testosterone around 8 or 10 or 11, they're just buying side effects. There actually may be more response in terms of follicles. Actually, it may not hurt them, but they don't need the side effects. And so if we can maintain them closer to the 30 to 60 total testosterone, 4 to 6, the side effects are more manageable, and they still get whatever the benefit is of the androgens. But so our testing is really to make sure they're not going over the top. As you know, here in the States, DHEA is not a controlled substance, and it's over the counter. And from batch to batch, the potency of what they call a 25 milligram capsule varies greatly. So when we started this years ago using so-called 75 milligrams a day in 3 divided doses, we'd struggle to get somebody total testosterone even up to 35 or 40. These days, some of the batches that come out, people are taking 1 or 2 so-called 25 milligrams a day, and they're shooting their testosterone up to 70 or 80. We mostly are monitoring the androgens to not go over the top because of that variation. Of course, if it was low, you might have to give them some more, but I haven't experienced too much low recently.
And on the CoQ10 side, there's nothing really to measure. What's your opinion on dosing and measurements?
So as you know, there's CoQ10 and there's ubiquinol, which is the isomer of the CoQ10 that's more active. When we're using ubiquinol, we use usually 100 milligrams 3 times a day, so a 300 milligram dose. When you're using straight CoQ10, you go up to about, we used to advise up to 1,000 milligrams of the regular CoQ10 because it's a combination of the less active and more active, racemic molecules. But no, I'm not aware of a response molecule test to look at to see if you're hitting it or not.
So on the CoQ10 side, excess is likely excreted, and you're not likely to get side effects from it of any significance?
Well, the side effects for CoQ10 have been reported. Sometimes it can raise liver enzymes. Sometimes it can cause nausea and a headache. I haven't had patients that complain to me about that myself, but I've read that other people have experienced that.
Are there any good sources of DHEA or CoQ10 that are not in a supplement but are in a food source or natural sources?
Well, I'm not aware of. Actually, I'm not aware of either. Are you?
No, I'm not. That's why I was just curious if you know anything that.
I mean, any in terms of androgens, I guess if you were taking Rocky Mountain oysters, you might get some androgens out of that.
Yes. Good point. And what do you have any other particular? So on the CoQ10 side, the value may not just be in the diminished ovarian reserve patients. Would you agree to that? Would you generally recommend that for many of your fertility patients?
Well, I mean, you could use. Um, I think that many of our fertility most of our fertility patients that we see have diminished ovarian reserve. I don't think we've ever given CoQ10 to an egg donor.
Right.
So I don't know that. I'm not aware of any evidence. I think all the papers, including the observational studies and things that you read, are dealing with people who've got some ovarian dysfunction of some kind. I have seen a paper where they used it for women with polycystic ovarian syndrome. I think that was a randomized controlled trial. It was a small study, and they showed a positive effect. So that would be the one case where they didn't have diminished ovarian reserve, but they did have a sort of ovarian dysfunction. They were looking at women who had PCO that had been unresponsive to normal stimulation. Someone with PCO are a little bit resistant to gonadotropin stimulation either, and then they fall over the top and they take off. Yeah.
We do tend to see more and more women at younger ages with more diminished ovarian function. Are they a different group, do you think, in either the cause or their ability to respond to things like DHEA and CoQ10?
So, I mean, I think being young is always an advantage. You even see the women in their 20s and 30s who come to you with premature ovarian failure, and occasionally we get those pregnant when one egg pops up and they make an embryo, or they sometimes get pregnant spontaneously on their own. Sometimes when we give them supplementation. I think the supplements, all these things seem to kick in and work better in younger people than in older people. It's just the advantage of being young. In terms of the insult, obviously, we see some young women who have diminished reserve, who have a genetic reason, the Fragile X permutation or some sort of other genetic problem. And whereas the older women are just dealing with natural aging and exhaustion of their ovarian supply of follicles.
And on the side of the male, parameters that you're recommending it based on morphology, motility, count, and those sort of things?
Yeah. So the male, for the men, they're coming here, we're recommending the same dose of 300 milligrams a day. And the evidence that's out there, as you said, shows improvements in motility. Some have showed improvements in morphology. There again is no hard evidence that shows improvements in live birth rates yet. And a lot of the male studies, because it's easy to do a semen analysis, are just looking at the results of semen analysis without looking at the clinical other side.
We have a couple of questions, and I have
Sure.
Dr. Barad here from Center of Human Reproduction here to answer some questions on fertility, diminished ovarian reserve, and we're talking about CoQ10 mostly. We kind of weave it in a little DHEA. But let's see here. Let's see. Onyi Ozoe. Ubiquinol, is it better than CoQ10?
Well,
she's taking, it looks like 100 milligrams ubiquinol twice a day.
Yeah, that's a pretty good dose of ubiquinol. In general, we're advising ubiquinol, and we're advising the 100 milligrams 3 times a day. But if you look across the country, the advised dose ranges anywhere from 100 to 600 milligrams, and none of it's based on studies. It's all based on everybody's sort of personal anecdotal experience in their practices. Ubiquinol is, as I mentioned before, just the active component of the CoQ10. So when you're taking regular CoQ10, it's a mix of something that would be like ubiquinol and something that's less active, and you can just think of the ubiquinol as being the more purified form of the active substrate. Yeah.
And let's see, from Kristen Kendall Polgardi, what numbers do you consider diminished ovarian reserve? And I'm sure age-wise and just AMH-wise. Maybe you could just chat about that a moment.
Well, Dr. Gleicher and I kind of came up with a concept of we called it premature ovarian aging. It's probably not a good term in modern nomenclature, but I guess you might call it ovarian insufficiency. But the idea is that it's natural as women move from even their 20s through their 50s, that the parameters we look at to measure ovarian reserve change. So a hormone like AMH will go steadily down as women age, and the day 3 FSH will go steadily up. And if you look at those parameters and limits of those parameters, what might be normal for a 38-year-old would be considered abnormal for a 25-year-old. So in the old days, we'd have a cutoff and we say if your FSH is less than 10, you have normal ovarian reserve if your day 3 FSH. But, if you are a 25-year-old and your FSH is 9.5, that's not normal. And that might be predictive of a problem. If you say that a normal, fertile AMH is around, 2 or 3 or 4, even, but if you're a 25-year-old and your AMH is 1 or 2, that's probably low for your age. So you can actually create nomograms, and we've created some, and others have created them that look at the expected AMH across the spectrum of age with the 95% confidence intervals. And if you fall outside that range for your age, then you're not doing as well as your peers. And it may mean that you may need a little more extra push to get there. In general, the 3 things we look at, the antral follicle count, the AMH, and the day 3 FSH and estradiol, tell most of the story in terms of laboratory testing. And what you want to know is that you're kind of like your peers. If you're not doing as well as your peers, then you've got some sort of what you might call diminished ovarian reserve.
And the use of DHEA and or CoQ10 may help ovarian and sperm function, but we might not see it in the AMH or the FSH. Do you think? Or we should?
I don't quite understand the question, but if in our experience, when we're supplementing women who've got evidence of diminished ovarian reserve with DHEA, we have shown that there can be an increase in AMH, and it's not in everybody, but in some people it could be quite dramatic. We've had people who came in with an AMH of less than 1 who increased their AMH up to 2 or 3 even on androgen supplementation.
But we might not always see it, but there may be some benefits even still. Or maybe the question is, if you're using the DHEA CoQ10, but you're not seeing an increase in the AMH or a decrease in FSH, would you still go ahead with fertility treatments and you may be seeing some benefits anyway?
Yeah, I think, the only way to fail is to not try. I think that these supplements probably do bring something to the table. We've seen, we both have similar practices. We see people who've failed at other places before they come to us. I've seen people, on these supplements do remarkably better than they were before, even if they don't change their numbers that much.
Yeah, yeah. Let's see. Carson Bunting, are there potential interactions between CoQ10 and any other fertility treatments or medications?
Well, the only other thing that we haven't talked about is the PRP kind of treatment. PRP is something that's kind of new in our field. Maybe we've been doing for about 3 or 4 years. I know you guys have been doing it for a bit. It's not clear exactly what it's doing or how it's working, but PRP is platelet-rich plasma, it simply means you take a patient's own plasma, you centrifuge it to remove the red cells, and then centrifuge it again to pack down the platelets, you then take that enriched portion of the patient's own plasma and inject it into the ovary. It's thought that the growth factors in the platelets will then act on small follicles and try to help them to do their job better. So it's another axis at which we can approach these small follicles and try to help them. As you know, originally there was a hypothesis that the platelet-rich plasma might scare up some brand new follicles from so-called ovarian stem cells.
Mm-hmm.
I'm not sure that the evidence for that is very strong, but we, have seen as we've been using it over the last few years, people in which there does seem to be some effect. And my own hypothesis is that it's that these growth factors are helping small follicles to do their job better, just as the DHEA and the CoQ10, and hopefully all these things are interacting in a positive kind of way. Someday we'll understand exactly how they do it and what the best combination is. But if you say, is there anything else? That's the only other thing. I guess the other thing might be a growth hormone.
That's a good one to talk a little bit about. And let me jump real quick to, because Dr. Conner had a question about the ovarian PRP, really dosage frequency, and what success maybe have you seen? I think there's an anti-inflammatory component to it, but again, we're speculating. But and who it benefits is always hard to tell.
Mm-hmm. Yeah. So the thing about PRP right now is that there is no standardization. So if you look at a PRP, a publication about PRP, if you look at 3 of them, they're generally preparing in different ways, administering it in different ways. There's no standardization for it yet. Even the volume that you're injecting is different in different studies. We started out our studies by just injecting less than a cc into each ovary of a highly concentrated PRP, and we weren't seeing too much effect. We increased the volume. Now we inject 3 cc's of PRP into each ovary, and we're seeing more of an effect with that higher volume. It's not clear to me if that is because we're putting in more PRP, or if there's a volume effect of stretching the ovary by injecting more serum into more plasma into it. We actually have a randomized controlled trial where we're comparing the injection of the platelet-rich plasma against the platelet-poor plasma. It's a blinded trial. So when we do the injection, we actually don't know whether we're using the rich or the poor, and we don't unblind them until after they finished an IVF cycle.
Interesting.
We make that work by basically doing the PRP without any cost. We deduct that cost from the subsequent IVF cycle, so we're trying to encourage people to be in the study. We're about halfway through with that recruitment. We won't have those results until another year or two, but it's going along pretty well, and it should be interesting. So we just don't know. Is it the platelets? Is it the volume? Is it the mechanical injection? All those factors are possible.
Do you think, because whether you inject once a week, once a month, whether you do it more than one time, and how long do you wait before you see a change? It sounds like we're still looking for those answers.
And we don't know. In this study, we're just doing it in a standardized way, waiting 1 month, and everybody gets the same stim when they come into their IVF cycle, so we can try to see what the effects are. But we have another group of patients who, either don't qualify for the study or choose not to be in the study and just choose to get PRP the way everybody else is doing it. And we've had people who've done PRP in the same cycle that we're doing the stim who had good response. We had people who our two patients who we published last year in a series of our older patients, two people got pregnant 3 months after they did the PRP. Now, I'm a little bit skeptical of the literature that makes a claim that there's a PRP effect for 6 months after the injection, because you start taking credit for anything that happens, in the next 12 months. Some people get pregnant, so whether or not they get it. So that's why we really do need some randomized controlled trials to try to answer the question.
Have you tried intrauterine PRP at all, or intraperitoneal, essentially, you think?
We've tried, for endometrial growth or for ovary?
Yeah. Well, for endometrial, for just intrauterine, but whether or not for open tubes, if you're getting a higher volume, you're getting some intraperitoneal
Yeah,
space.
so I've certainly read some of the studies where folks were putting high volume into the uterus and having it go out the tubes and, I guess, coat the ovary because the ovary is right there. And no, we haven't done that. And I think it's a little bit different coating the outside of the ovary with plasma than injecting it into the ovary. There's probably tissue effects that you get from injecting into the ovary, activate the platelets in a way that you might not just passing it through. So it doesn't make physiological sense to me, but doesn't have to make sense. It might work.
Well, I think like the oil contrast for an HSG, where you get some anti-inflammatory peritoneal effects, you may get the same thing with the high volume PRP that essentially reduces inflammation intraperitoneally, which may enhance, again, the egg and sperm interaction or implantation. All these things may happen.
Well, we've all experienced that person who gets pregnant the month after we do the HSG. So yes. It's possible.
Yeah. Let's see. Jolie asked a question about CoQ10 safe in PCOS patients to take. Answer is
yes.
Good. Let's see. Placental. Now, stem cells from non-autologous are not allowed in the United States for our particular use.
Correct. And even I'm sure you've had some too. I had a patient that went to Turkey and got the stem cells from what's his name? I can't pronounce his name, but Ygritte with the C, long name anyway. He's got a clinic in Turkey, and he did a combination of PRP and stem cells that were taken from bone marrow from the patient's hip. But I'm not aware of anybody using non-autologous stem cells. Are you?
Well, not for ovaries or intrauterine. Yeah. In the orthopedic world, they're allowed to in America. And then I know people that are going to Mexico. We have a colleague that works out of Mexico that is doing non-autologous and doing a placental and or cord blood.
Yeah.
But again, I'm not convinced that we really know this answer, and it's really great that you doing a research project on this, and certainly for patients who are looking to be involved in that, I encourage them to certainly reach out to you for sure. Human growth hormone. Maybe we could talk briefly about that, what your thoughts are, and what the benefits may be.
So, human growth hormone is a pituitary hormone. For years, people were actually extracting it from pituitaries, and that became a problem because people were getting slow viruses from the pituitary extracts, and the pituitary extracts were all taken off the market, and they have now synthetic growth hormone, which is marketed to people with growth hormone deficiency, and that wasn't much of a market, so they created a market for short children. And I don't know if you know, I've known a couple of people who had kids that are a little bit short, and they were doing these injections of growth hormone, and then they got some height. Although I think the pediatric literature suggests that it doesn't really change their adult height as much as it helps them to catch up faster. It may be small change, but I haven't looked at that literature in a while. It became apparent that when synthetic growth hormone became available, people started seeing if it might be helpful for women with diminished ovarian reserve. And again, if you look at the literature, there are several different doses that have been used for growth hormone, and several different ways of administering it. A lot of people these days are using growth hormones simultaneous with ovulation induction. The mature follicle actually doesn't have much in the way of growth hormone receptors. The smaller follicles, the preantral follicles, do. For that reason, some people are backing up the growth hormone administration to start about 2 weeks before an ovulation induction, which makes some sense. And Dr. Gleicher and I decided to back it up a little bit more, and we've actually done it for about 6 or 8 weeks before we come to stimulation, along the same lines that we're trying to treat these small follicles. The problem with growth hormones is pretty expensive, and so it's not like PRP where you can just take it out of somebody's arm and then randomize it. It costs thousands of dollars over the extended period of time. Of course, all our fertility medications do, but it became hard to create a randomized controlled trial for that. We tried to do it, but we couldn't quite get the recruitment going that we needed for that. But if you look at the literature, the Cochrane reviews, which are now about 8 years old, showed that there was an effect of growth hormone supplementation in women with diminished ovarian reserve. There was less of an effect if you looked at women who had normal ovarian reserve. Which makes sense. If you're going to make a difference, you're going to make a difference in the people who had a problem. The doses that people were using sometimes were quite large, and there are significant side effects when you take growth hormone. I don't know if you've seen them in your patients, but we've had 1 or 2 patients that got fairly bad carpal tunnel syndrome. I had one patient who had sort of a carpal tunnel. It's like a carpal tunnel. It's extended all the way up her neck, and she got like a torticollis from it. Her neck kind of twisted like this. And the average patient gets some swelling, swollen ankles, a little, discomfort in their joints is pretty common. So we generally use just a fairly low dose, like 1 milligram of Sazon or Omnitrope. And the thing is that they come in different dilutions, so you have to go back and figure out what 1 milligram is. And We do a daily dose over, if we can get it, at least a month before they start a cycle. But, over the years we're doing it, we weren't seeing too much response. So recently, we've been following people, actually all of our patients with IGF-1. And IGF-1 is the end hormone of growth hormone. In fact, there was a little synergy talking about, there was early literature suggests that DHEA acted by increasing IGF-1, if you remember the really early studies. But anyway, so we looked at all of our patients' IGF-1, and we had a sample of a few thousand at the time we did the analysis. And we looked at, divided into tertiles. The lowest tertile started about 125. Now, if you look at the normal levels, normals are 75 or so and over. So we're still in the normal range, but we're only advising use of growth hormone to those people who have IGF-1 in the lower tertile, so less than 125. And in that way, we're trying to isolate people who are more likely to be responsive. The Colts to Newcastle. You want to treat somebody who's some evidence of deficiency to try to see some response. A lot of people are not in that lower tertile, although today I saw two people who were actually below normal at 65 and 70 IGF-1. So if you look, I guess you find it. But I mean, we've had better evidence of response when we kind of restrict the treatment. It's expensive and causes side effects. We don't want to be treating everybody, but we've restricted it to those people. Now, the interesting thing about IGF-1 is that it's a little bit variable. So I need two levels that are low, at least 2 weeks apart, to drop the hammer and go for it. There are food supplements that can raise growth hormone and I guess IGF-1, and that's L-arginine. They say if you eat a lot of turkey, it can raise your growth hormone. So it's interesting. There are food supplements that can raise growth hormone, and it's just one more tool in the armamentarium. But we try to restrict it to people who have, some evidence of need.
And if you're using it, you're typically going to give some before stimulation for 2 weeks at least, maybe up to 4 weeks.
We would like to get 4 weeks, but at least 2 weeks. Yeah.
And what about estrogen or progesterone priming and androgen priming? Do you add those?
We generally do estrogen priming. I tend to use a patch. I've been using like a 0.05 patch recently. We were using 0.025 before. I know a lot of other people use a 1.0. I start about 10 days before stim. And I don't want to raise the estrogen up too high. I find on the 0.05 patch, it gets them up to about 90 to 100, maybe 110. And then you just think of that as the foundation. And then when you start your stim, you want to see it rise up. Some people, I continue the patch into their cycle. Some people, I'll stop at the beginning of the cycle. And I can't tell you how I make that decision, just sort of gut reaction. The idea is there's pretty good evidence in rodents that it sensitizes gonadotrophin receptors. The evidence in people is less. I guess we're looking for the priming to try to hold back that early emergence of a dominant follicle, which we sometimes see happens in people with diminished ovarian reserve. If my estrogen prime doesn't do it, I may move up to the higher dose patch, or I may add progestin to hold it back. What we're trying to balance is the problem of overly suppressing somebody. So I've had patients where they were on the patch. Actually, I had somebody who erroneously used her. She'd gone through some frozen embryo transfers before and had leftover 1.0 patches. And when we told her to do prime, because she'd gotten some PRP and she was trying to use her own eggs again, we told her to use a prime. She used the 1.0 patch again, and that just shut everything down. So she came in and she had like 2 or 3 antral follicle count. So you don't want to overly suppress people with this priming stuff, but you have to find a balance between holding back that dominant follicle and maybe doing some of the sensitization and overly suppressing. And it'll be on a case-by-case basis. Sometimes it's trial and error for a particular patient.
There's a good question here by Kieran Flores about any specific formulations or delivery methods for CoQ10 that have been shown to be more effective for fertility enhancement.
Well, as I said, we generally recommend the 100 milligram 3 times a day of ubiquinol. We happen to have an affiliated source, this nutraceutical company, and our patients tend to use it from that source, the Avenergen, again, there are other sources, and people use it. Now, in terms of evidence, the evidence is what it is. There's no strong evidence one way or the other. I think the evidence is still being developed, and we'll all look forward to answering the questions when we know the answers. Yeah,
that's the beauty of science. We're always here to listen, learn, and we find new things out. Any thoughts on a dosing for the stimulation for these lower reserve patients?
Yeah, I think it's been there's good evidence that if you use less gonadotrophin in the average patient, you get fewer eggs, and that we will go up to a max dose of say 450 of an FSH preparation and 150 of Menopur, just to get a little bit of LH in there. We've used some low dose HCG as well. Mm-hmm. But I think again it's something you have to kind of titrate to the patient. We've recently been varying our dosing. Sometimes I have a patient, we're one of the things we're doing differently is, as we've talked about before, is that our older patients, especially our patients over 44, we've been triggering them at smaller follicle sizes. So our somebody over 44, 45, we may be triggering at 12 to 14 millimeters. What we don't like to see is they come in on their 3rd or 4th day of stim and they're already 12 or 14 millimeters because they've kind of pushed it along too quickly. So in those patients recently, we've been reducing the dose to try to drag out the timing to give it a little bit more time to get to that the trigger point, with the idea that it may give the egg a little bit more time to develop. So we have been working with the lower doses. We're not big believers in a mini stim, but we have done it, and we've even done natural cycles in people. I think if you've shown that on a high dose you only produce 1 follicle, 1 egg, but you're still cycling, then why spend the money on all the medication?
Right. So are there any other questions maybe I haven't asked, or some things that you wanted to make sure we got a chance to talk about?
Well, just finishing up on the dosing, one more thing.
Yep.
There are a lot of observational trials out there which have suggested that women who are exposed to high-dose gonadotrophins may have produced lower quality eggs. I think that the problem there is that in an observational, when they're doing retrospective studies, the women who were getting the high dose probably were the women who needed the high dose, and that's why they had lower quality eggs. So you have to be careful of the literature. There is some randomized controlled trials out there that show some negative effects of high dose as well, but I think it remains to be seen. We try to get more eggs so we get more embryos. More embryos gives us a better chance of finding the golden embryo in the bunch. Anything else?
Acupuncture, are you guys sort of or
we have patients who appreciate having acupuncture. We invite acupuncturists into our place to do it.
Right.
If you believe in the whole chi thing, it's supposed to improve the blood flow. I don't presume to understand it very well, but I think in the worst case, it's kind of nice to have somebody laying on hands and doing something, and I think it helps calm patients down a little bit even to go through the acupuncture. We mostly are doing it when they come here. It's before and after their transfers, and it's kind of like a little Zen session for them, around the time of the transfer. They calm down, I think.
There's so much stress and struggle in this whole process, and that we need to infuse a little bit more of that in all of our lives. And
absolutely, sure.
Dr. Barad, thank you so much for joining me today, and we're going to keep this so people can go back to it. So it'll be on our site, and invite people to check out Center of Human Reproduction with Dr. Barad and Dr. Gleicher to learn more about DHEA, CoQ10, PRP. And
if you want to join the trial, let us know.
Yes. And how long is it going to go, do you think?
I think we're about halfway through. It took us about 2 years to get halfway through, so we probably have another year and a half to 2 years to go. Recruitment during the pandemic was hard to get people in, so we're doing a little better now. I think we've recruited more people in the last 6 months than we did in the year before, so it's moving along.
Well, hopefully this will help bring more patients that'll help answer the questions. We appreciate it.
And Dr. Kiltz, thank you for what you do. Thanks for having us on this podcast. And I know that you work hard to take good care of your folks up there too. So we're all in this together.
We absolutely are. And I look forward to us doing something similar again, just to answer questions, because there's such a need for more thoughts and ideas. So again, God bless and thank you, everyone.
Okay.
Thanks.